In this video, we are going to discuss the specific findings on chest X-ray in different types of diseases. First of all, we will look at the pneumonia. In the pneumonia, there is dense or patchy consolidation. So, if the consolidation is present, which may be dense or patchy, and usually unilateral, then we will consider the differential diagnosis of pneumonia. It may contain air bronchograms, and air bronchograms are air containing bronchioles running throughout the consolidated lung. In the lower zones, pneumonia may be difficult to distinguish from effusion, so both should be on your differential list. And remember, there is often a paraneumonic effusion. So we will see the diagrams of the consolidation. Here is airspace opacification, which obscures medial aspect of the right hemidiaphragm, indicating the right lower lobe pathology, and the right heart border is preserved. Here is the consolidation or opacification present. The diagram B shows an indistinct right heart border. There is no specific demarcation of the right heart border with the preservation of the right hemidiaphragm in keeping with the right middle lobe consolidation. So airspace opacification, which obscures the right heart border, indicating that the pathology is in the right middle lobe, and in this case right hemidiaphragm is clear. In this case, the left heart border is clear, and airspace opacification, which obscures the left hemidiaphragm, indicating that the pathology is in the left lower lobe. And in this case, there is a septal consolidation with an indistinct left heart border, indicating lingular consolidation. So these are the consolidation at the different parts of the lungs, indicating pneumonia of the different sides of the lung. The silhouette sign is useful for locating in which lobe of the lung the pathology is located. Normally, there is a sharp border between the aerated lung and the soft tissue of the heart and diaphragm. This is due to the large differences in the number of X-rays attenuated by the soft tissues, which is the relatively high proportion of X-rays, and the lungs, which is relatively few X-rays pass through the lungs. And if there is consolidation, the normally aerated lung is replaced by fluid or pus. This attenuates X-rays to a similar extent to the heart and diaphragms. The usual sharp border between the lung and these structures is thus lost, and if there is consolidation in the lobe abutting these soft tissues. So it is necessary to know which lobes contact the heart and diaphragmatic borders in order to be able to use a silhouette sign. Diaphragm, left and right lower lobes, right heart border, right middle lobe, left heart border, lingula, part of the left upper lobe. Remember that pathology can affect more than one lobe. It is not always possible to identify in which lobe pathology is located. In these cases, describe it as affecting the upper, middle, or lower zones. Pleural effusion. Now we will see the findings in the chest X-ray with the pleural effusion. In this case, look for the blunting of the costophrenic angles. Here is a blunting of the costophrenic angle and homogeneous opacification. This is the homogeneous opacity present in this right side of the X-ray, and a fluid level manifesting as a meniscus. There is a fluid level manifesting as meniscus with the concave sign. In this case, a large right homogeneous opacity which fills most of the right hemithorax. The right costophrenic angle has been obliterated and a meniscus is present. These findings are consistent with a large right-sided pleural effusion. Then comes towards the pulmonary edema. A, B, C, D, E, F can be used and mnemonic, For the features of the pulmonary edema, usually only some of these X-ray signs are present, and the diagnosis is made in conjunction with the clinical picture. A is for alveolar and interstitial shadowing. B for Carlaby lines, which are the little white horizontal lines usually in the lateral lower edges. C is for the cardiomegaly or cardiothoracic ratio is greater than the 50% on the PA X-ray. D for upper lobe venous blood diversion, which is a prominent upper lobe vasculature relative to the lower zones. E for effusions. F for fluid in the horizontal fissures. So this was the mnemonic for the pulmonary edema. Now we will look at the picture of the pulmonary edema in the X-ray. Here is the PHS X-ray show interstitial edema and Carlaby lines. Here are the Carlaby lines, and these are the Carlaby lines, and is the interstitial edema, cardiomegaly, upper lobe venous diversion. Venous markings are more marked. Carlaby lines, cardiomegaly, and upper lobe venous diversion. No pleural effusion are evident, but the findings are in keeping with the pulmonary edema. Now coming towards the case of the pneumothorax. In the case of the pneumothorax, air within the pleural space is present. Loss of the lung markings in the peripheral lung field. You may also identify a discrete lung edge. With a simple pneumothorax, there is no mediastinal shift. In contrast, if there is a tension pneumothorax, there may be a tracheal or mediastinal deviation away from the pneumothorax and flattening of the ipsilateral dome of the diaphragm. A tension pneumothorax should never be diagnosed by a chest X-ray. It is a medical emergency and is diagnosed clinically and treated immediately with needle thoracocentesis. Is the chest X-ray showing pneumothorax. At the periphery there is no lung marking visible, and the distinct lung edge is present, but there is no flattening of the hemidiaphragm and there is no mediastinal shift. So this is the case of the simple pneumothorax, and there is no evidence of the tension. Now coming towards the case of the Lubar collapse. Look for the loss of the volume. A raised hemidiaphragm is present ipsilaterally. Tracheal and mediastinal shift is towards the collapsed site. Displacement of the hida. Narrowing of the space between the ribs compared to the opposite side. Left upper lobe, also called veil sign, in which the whole lung field looks like it is covered by a veil. This can be difficult to appreciate. Lufschell's sign is sometimes seen, in which radiolucency in the left upper zone around the aortic arch is present due to the compensatory hyperinflation of the left lower lobe. In this case, trachea is deviated to the left, indicating the left-sided volume loss. Radiolucent rim. It is a radiolucent rim outlining the aortic arch, presenting Lufschell's sign, and there is classic veil-like generalized hazy opacity of the left hemithorax and elevated left hemidiaphragm, indicating the left-sided volume loss. Now coming towards the left lower lobe, which a sail sign is present, which is a sharp line like the edge of the sail at the same angle as the left heart border, giving the impression of a double left heart border. The medial part of the left hemidiaphragm will be indistinct, but the left heart border clear. Is the triangular retrocardic opacity in keeping with the sail sign of a left lower lobar collapse. Double left heart border is present. The medial aspect of the left hemidiaphragm is indistinct, indicating a pathology within the left lower lobe. Now comes towards the right upper lobe. In this, increased opacification in the right upper zone with raised horizontal fissure is present. which usually has a concave border. This abnormality is well demarcated by horizontal fissure. Golden's S sign is present if there is an associated right hilar mass. Increased opacification of the partially collapsed right upper lobe. Concave border of the elevated horizontal fissure is present, and convex border of a right hilar mass is present. Trachea is displaced to the right, indicating the right upper zone volume loss. Together these make up a Golden's S sign of the right upper lobe collapse. Now right middle lobe. The most difficult lobar collapse to detect on chest X-ray is the right middle lobe. Look for depression of the horizontal fissure and an indistinct right heart border. CT is much better for detecting the middle lobe collapse. Here is the depression of the horizontal fissure and displacement of the trachea to the right, indicating the volume loss. There is opacification within the right lower zone, an indistinct right heart border, but preserved right hemidiaphragm, indicating right middle lobe pathology. So these were the some findings on the X-ray of different pathological diseases.